Dear viewers, we will be talking about drug disposition in this lecture. You are quite familiar that drug disposition plays a vital role in the pharmacological action of drugs. So these are the objectives which are self-explanatory, and we will be primarily focusing on drug disposition with respect to volume of distribution and the factor affecting the distribution of drugs. So, important point to remember that drug disposition includes drug distributions and drug elimination. Remember, elimination means the removal of drug from the body. So it is excreted from the body through different routes and mechanisms, which will be discussed in separate lecture with you. So drug disposition is sum of the distribution and elimination. So the amount of drug that reaches the general circulation mean the drug. So you see, if your patient takes a drug and then it goes to the stomach and then small intestine, which is the maximum site of absorption, it goes to the livers, passing to the liver, mean hepatic phosphorus effect, and then reach the blood. And this once reaching the blood, you see, so then to the kidneys, you see, then it is G4, glomerular filtration rate is there, so blood supply is there, blood efferent arteriole is there, and what you can see, then the proximal convoluted tubule, loop of Henle, distal convoluted tubule, and it goes into open into the collecting duct and pylorus, and it reaches to the passing to the ureter to the bladder and urinary bladder, and it is to the urethra. You see, so mostly the drug is eliminated by renal route, but here, if you consider that there is what you can say gallbladder is there and it has its own blood supply. So blood supply, this is purely diagrammatic to the gallbladder, and then from the gallbladder you see when it secretes into the hepatopancreatic duct, you see, and here the drugs is absorbed again. So it goes and it reaches the blood circulation as well, and then it comes, so you see, so there is a circulation like this. This is called as, this is intestine, so it is named as entero, and passing through the liver, you see, so it is called as hepatic circulation. And remember, so some of the drug is then if this is the green amount is the drug, it's being given by the tablet. That tablet dissolves and disintegrates, and it comes here, it is absorbed. So what happens? So some of the drug is then eliminated in feces as well. So the most primary route is the renal route, and the second is the fecal elimination. You see from the body. There are some through the oxygen and inhalation routes, and so many through the sweating. But most primary, the more important route is the renal and the fecal elimination. So if we talk about the enterohepatic circulation, enterohepatic circulation, so it means that we talk about the fecal elimination, or to the what you can say to the rectal route. So this is very important that in the elimination usually we consider the drug metabolism as well, and metabolism usually leads, once metabolism is there, so it produces polar compounds in general, and the polar compounds you see or metabolites are water soluble. They are more water soluble. So once they are more water soluble, then it is excreted very easily by kidneys. So this is very technical point to remember. So when we talk about drug dispositions, you see, so it's absorption plus elimination. Remember, so when you take a dose, particular amount of drug you take, so the amount of drug that is absorbed at the absorption site, then it goes, the amount of drug reaches in the body, and mean in the blood that is there, in the tissues, and the amount of drug that is excreted either to the renal route or kidney routes, and the amount of metabolites that also present inside the body, that would be another, and it is also the sum of the amount of drugs metabolites that is eliminated by the kidneys. So what you take the total dose inside the human body, what happened to it, this total dose, is the amount of drug is absorbed plus the amount of drug inside the body. When we talk about inside the body, it is in the blood, keep in mind, and it is in the tissues as well. But this is not so simple. When it reaches the blood, so from blood it reaches the tissues as well. And from blood going to tissue is a terminology used for this that is called distribution. So you see, what is important, what you take a dose of a drug, so it is absorbed, it is distributed, then it is metabolized, and then it is eliminated. So let me draw for you some three words: ADMA. So absorption is there, distribution is there, metabolism is there, and elimination is there. Now, but this is not so simple. You know, each cells of drug sometimes behaves like a simple compartment. So in order to understand that when you take a drug, it goes to the blood, and from the blood it is then going to the tissues, mean the peripheral tissues. And remember, this shows that there is a balance, mean what you can say, I can draw it like this one, equilibrium between the drug reaches the peripheral tissues and drug reaches the central compartment. First, this is one compartment, this is the second compartment, you see. So this is called two compartment models. But for simplicity, we will consider this for your understanding that absorption is there. Absorption means the absorption constant, and then it reaches the blood in the central compartment. And from the blood, it is eliminated either to the renal route or the exhalation route, or as the case may be, to the fecal route. And that goes outside the body as eliminated. So, important point for understanding is that for simplicity, we will consider this as a single compartment model. We will select this compartment model. And why we study this? We study this because we have to control on the drug response and drug response curve, you see. And that is not so simple, you see. For example, for that you have to understand the amount of drug that reaches the general circulation. For example, if I draw it for you, so your other tutors might have told you that when we plot the amount of drug in the blood on the y-axis and on the x-axis, you see, we plot the time. This is called plasma time concentration curve, and to the whole root there is absorption, then distribution is there, and then elimination is there, you see. And we cannot plot the metabolism here on this plot, because metabolism is a phenomena which cannot be plotted here. The most important point here is this is the absorption, and this absorption, you see, then this is distribution is also there. Distribution is also there. Distribution, and then phase of decline starts. You see, this is elimination. Elimination. So, point to remember is that when you consider these drugs, you see, drug response. So we have to control the drug response, and for that you should understand the plasma concentration of a drug. Therefore, it will tell you the most possible sites of action of drugs. This is sites of possible pharmacokinetic. You see, interaction. When absorption is there from the small intestine, you see, absorption. This is the absorption sites. So here interaction may be there. Here interaction. So on the absorption side, interaction may be there. There may be the drug metabolism. Metabolism means that in shape of liver. In liver, there is one enzyme induction may be there, and enzyme inhibition may be there. So this is the second place of what you can see of possible drug interaction. And then how quickly that is lost, metabolized, and this is also a development in metabolism and elimination. Sometimes metabolism is inhibited, mean the slowing down of the elimination phenomena, and this could be another possible site of interaction of drug interaction, and this will lead to increase in the plasma level, and subsequently the response may be increased. Or the toxicity of drugs, the toxicity of drugs will be increased. So that is why this pharmacokinetic interaction, these are the possible signs of pharmacokinetic and drug interaction, and that is why we study it. Now, regarding distribution, consider that when the drug is reached, for example, this is a absorption, distribution, and elimination is there. You see, this is concentration, this is Cp maximum, plasma concentration maximum, and this is the time maximum, T max. But it's not so simple. You see, when you take drugs, it reaches the blood, and once it reaches the blood, what it happens that it passes through from the from the blood, it reaches through interstitial fluids, then it penetrates into passes the cell membrane, and then the intracellular fluids. So you see, the drug has to pass through many barriers, and these are the points which we consider in the drug distribution, and that play a vital role. You can consider this as a single compartment, this is another second compartment, third compartment, but for simplicity, we will consider that the drugs from the blood goes to the tissues directly. We will consider it so that you shall easily understand this concept. So the drug distribution is the process which the drug is reversibly. Reversibly mean that it comes here and it goes back here. And from blood it goes to tissues, and from tissue it goes to blood again. And enter the interstitial fluid and the cells of the tissue until equilibrium is established between the unbound drug and the plasma. Remember, this is a technical point. Unbound drug means free drugs. That is very important, and it is the free drug that produce the pharmacological response. What is the main purpose of this process of drug transport across the membrane? It reaches the site of tissues, site where receptors are there, and that produce the pharmacological response. Now, factors affecting the drug distribution. This is very important because students must know what are the key factors, and these factors are self-explanatory. You can just have a watch on that. Let me proceed to the other. So let's discuss one by one. Factors affecting distribution of drugs. You see, factors affecting distribution of drugs. If the drug is reached to the central compartment, you see here that is. So there are some organs which receive the drugs very instantaneously. It reaches the brain. It reaches the supply is very fast. High blood flow towards the brain is there, towards the heart is there, towards the kidney is there. But remember, to the skin, the blood supply is low, and same is for the what you can say low distribution is there to the skeletal muscles, and of course to the adipose tissue, because it depends upon the penetration of drugs, because the blood carries the drugs, but in the nature of the drug and this barrier will decide how it's going to penetrate and distribute inside the tissue. Keep in mind the rate of perfusion of the kidney, brain, liver, skeletal muscle, and adipose tissue. Now, in certain cases, when the drug is much more lipid soluble, it goes from the blood and goes and deposit in the tissues, adipose tissue. So, for example, if we consider tipentol and propofol, which are used, tipentol, you know, is used for the induction and maintenance of anesthesia. But tipentol problem is it's much more highly lipophilic drug. It goes and redistribute in the tissues, and from the tissues, then it goes to the blood. Remember, keep in mind this point. So the half-life is increased, and probably this was the reason that propofol replaced tipentol sodium. Why? Because the recovery process in certain case it was not smooth as redistribution prolong the half-life and recovery phenomena. So blood flow to the organ is very important, but blood flow is not so simple, dear students. You know, there are some cases where you can find that the capillaries are continuous or the capillaries may be penetrated. Capillary mean that they have fine channels, pores through which the drug can easily pass through. But in case of continuous capillaries, you see like the blood-brain barrier, you see that proposes. So there is a astrocytes outside, you see, and the lumen is there, and it is then covered by the pericytes, you see, and the basal membrane is there. So it's not so simple, it's not easy that the drug will goes and easily out. Only lipophilic, only lipophilic drug will ooze out from this. Otherwise, that will not that will the hydrophilic will not ooze out from the blood-brain barrier. So therefore, only lipophilic drug can cross the blood-brain barrier. The third point is the factor affecting that the chemical nature of the drug. As we said in the previous slide, lipophilic drugs uh, easily 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 cross the blood-brain barrier, but dissolution is really a problem. And the hydrophilic drug dissolve very easily, but their penetration to the cell membrane is very problem. Therefore, the hydrophilic drugs only pass through the penetration, you see, and the molecular weight of the drug is also very important, more than 7,000 atomic mass unit or Dalton, you see, and a big molecule cannot cross through this penetration, you see, very easily, and the size of the molecule is also affecting the distribution of drug. Then the degree of ionization is very important, and you know how strongly a proton is attached to the concerned drug molecule. So the lower the pKa value, mean that the strong dissociation of that particular acid will be, and very easily it will be dissolved. So the strong acid will have less value of pKa, and strong acid will easily dissociate in water. So the fourth point is the binding of drugs to plasma proteins, and this is a very technical point to understand because albumin will usually it have a negative charge. Consequently, an acidic drugs with proton that can easily be attached with this, and salicylates are the classical example of drug that is primarily attached to the plasma albumin, and these alpha-1 glycoproteins, basic drugs attached with alpha-1 glycoprotein, whereas beta-globulins bind with thyroxine and sex hormones. Now, on the right side, you see this is a plasma protein, and the drugs have been a drug with green, this unbound drug, this is unbound drug, and this is bounded drug. You see, this is bounded drug, and it is the free drug that gives you the pharmacological response. Now the point is it reaches the blood. From blood it has to go out to reach the site of receptors. Receptors mean tissues, and it is the tissues that have receptors, and then the drug will give you pharmacological response, you see. And this is for that pharmacological response you have to the binding of drug to the plasma protein is going to limit this response. If the free plasma level is high, the response will be high, and much more level if it is high crosses the toxic level, then it can create problem for the patient. So thus there are drugs which also binds to the lipoprotein, you see, and the basic drugs also bind to lipoprotein. So this is very important. Albumin attached acidic drugs with the alpha-1 acidic glycoprotein basic drugs are attached, and beta-globulin, thyroxine, and sex hormone, whereas lipoprotein, so lipids plus protein, which are usually binding to the basic drugs. So the degree of binding of plasma protein is going to ultimately affect the pharmacological response, as I referred to in the previous slide. But most precisely, you see what happens when the drug is there, absorption is there, it reaches the general circulation, mean blood, and then attached to the albumin or glycoprotein, depending upon the nature of drug. Acidic will attach to albumin, basic will attach to glycoprotein, and then the bound form, then it attains an equilibrium with the drugs and then the tissues, you see, and it is the free drugs, you see, that reaches the site of tissues and the receptor and give you the pharmacological response. Now, characters of protein binding, you see, if it is reversible, that should be reversible, and if equilibrium is there, so it can then it can be helpful, especially in maintaining the normal pharmacological response and the maintenance dose. So there is a difference between a free drug and a bounded drug to the plasma protein. A protein-bound drug, you see, is non-diffusible, whereas free drug is diffusible. It is pharmacologically active, especially in case of free drug, and pharmacologically inactive if it is plasma protein-bounded drug. Not metabolized and excreted by the glomerular filtration. Why? Because it already with plasma protein and is not exposed to the metabolism. And it is the free drug that is exposed to the metabolism, and converted to the more polar compounds and eliminated easily from the body. The significance of increased binding drugs to plasma protein, this plays a very important role, especially, for example, from the blood, it will go to the tissues. It is the tissues that have receptors. Remember, as I said in the previous slides, I'm repeating it again and again so that you will understand. And thus, distribution is very important from here to reaching the tissue. This is called distribution. And the pharmacological response is also being regulated by the free drugs. Consequently, it is the free drug that's exposed to the metabolism, and subsequently metabolism leads to polar compound which will be eliminated from the body. So thus, we discuss that this free drug is available for dialysis in poisoning of a drug which is high plasma protein binder. Keep in mind this point, and this can be helpful once you will be doing managing toxicology of a drug which is highly plasma protein binding or low plasma protein binding, and that will decide the ultimate fate for the detoxification mechanism. You see, this is a drug which is not bound to plasma protein heavily, and this is a drug which is strongly bound to plasma protein. And if it is strongly bound to plasma protein, it passing through the blood vessels, you see, it goes, renal elimination is less because it is strictly bounded with plasma protein. And here you see, on the left side, it reaches the effector organ, the response is high as compared to this one, and biotransformation is high as compared to this one. Why? On the left side, because the free drug concentration is high, and it is very easily eliminated in case of the drug with the less plasma protein binding, and very slowly eliminated if it is more plasma protein binding. So this is how in the drug disposition the plasma protein binding is playing a major role in the elimination of a drug. There are two theories. There are some drugs are class 1 drugs and the other are class 2 drugs. Class 1 drugs have a very low total dose ratio to the capacity ratio, mean that rate you see on this side, this is the amount of drug being given, and these are the albumins, and the free albumins are there, and the ratio is very low. You see, dose to capacity ratio with respect to the number of this albumin that is low. And if this is high, you see, it means the albumin are saturated and the free amount of these drugs molecule is very high. Consequently, this drug is having a high risk of toxicity. Mostly, in majority of cases, drugs belongs to class 1 type of drugs. You see, and that is majority of the more clinically used drugs are belonging to this category of class 1. Now, when there is a competition of one drug for the other, for example, warfarin is class 1 drug, and it is given with along with sulfonamide, which is class 2 drug. So what will happen? In case of this class 1 drug, for example, we consider warfarin here, and that goes and attached with these plasma protein albumin, you see. And when you give a second class 2 drugs, especially like sulfonamides, so the free level of drug, you see, is very high, and that have a very high affinity for this protein as well. So what will happen? It's going to affect how the free level of this red one, you see, here were no free red drugs, and here the free level of this warfarin is now increased, class 1 drug. So what will happen? The toxicity of warfarin is increased beside the pharmacological response. So this is a technical point to understand that in case of drug disposition and distribution, the possible drug interaction at the site of plasma protein binding, when either second drug is added and have much more affinity for the plasma protein binding, and it can displace the previously bounded drug, and the toxicity of the previously bounded drug may appear. So the factor that increase the risk of adverse effects, especially when competition is there with the displacement of drug. You see, drug if has small volume of distribution, and you see it has narrow therapeutic index like digoxin, and then it can create problems in these patients because if the drug is easily displaced and the therapeutic window is very less, then the toxicological symptoms of the drug will appear. So, binding of drugs to cells and tissue constituents. This is very important. These are the drugs which attach to the cells of these. For example, digoxin goes and attach with muscle cells, you see, and liver chloroquine, which is a weak base, so compare with that with insultine, and you see bone and teeth calcium, that tetracycline, that make complexation and permanent teeth staining is there. And in case of thyroids, you see drugs that interfere with iodide pumps, you see that can be a problem, and so on. In case of DDT, which is dichloro biphenyl trichloroethane, you see, which is much more lipid soluble drugs, and it goes and attach and redistribute in that fat tissue, and elimination within the lung, you see. And similarly, arsenic poisoning in case of skin and hair, you see. So these points are very important, especially in toxicology and toxicological manifestation, even detoxification mechanism as well. So far, the drugs to binding to tissue is concerned, you see, and when it goes and attached with tissue, so remember the elimination is prolonged, and once the elimination is prolonged, so the half-life of the drug is prolonged or increased, and therefore sometimes the toxicity of the drug may be increased. And you can see, in case of chloroquine, which goes and attach at the level of eye, and you can see these are the retinogram, you see, especially, and here you can see typical bulls like eye, and that is one of the chloroquines or hydroxychloroquine toxicity that is attached, that is specific for the toxicity of chloroquine or hydroxychloroquine. So, and the phenomenology like that of bull's eye. So some drugs goes and sit at the particular tissue sites and can create problem for you. So you shall inform your patient about all these possible adverse drugs effects. Like quinolones goes and that produce toxicity. So you will tell your patient, do not go out in the sun when you are going to take quinolones. These are the other factors, you see. Some transporter factors may be there, and that can create problem for you. Other factors, edema, pregnancy, and that can also affect the distribution of drugs. And volume of distribution, at least now we have to clear what is volume of distribution. So distribution of drugs to some special organs due to the presence of special barriers. Before we go to the volume of distribution, let we discuss the distribution of drugs to some special organs. And among the special organs, you see, when we consider the blood-brain barrier, BBB, you see, and you can see this is the lumen of the capillary supplying the brain. This is a classical basement membrane, and in the astrocytes, you see, are there, and you cannot find any slit or finasteride. That is why the lipophilic will easily cross it, but the lipophilic cannot cross it because there is no fenestration inside the endothelial wall of this capillaries that are supplying the brain. So this gives the concept of blood-brain barrier, you see. So remember, studies have shown that stress increases the inflammation, and once inflammation is increased, so the porosity that may be increased, and then it can create problem for you. So far distribution to the drug that is increased, and that distribution increase. Why? Because of increasing the permeability. Penicillin is water soluble, cannot cross the blood-brain barrier, you see, and then it can create problem for you, especially in case of certain drugs cannot cross the blood-brain barrier, and like if there is tuberculosis of the brain, so intrathecal administration of the drug is required. So So it depends on the types of the tissue that where you want to carry the drug. So the passage of drugs to some fetal placental barrier, you see, this is also a technical point, and more, remember, placental barrier are there, but they are more permeable as compared to blood-brain barrier, and lipophilia drug can easily pass. And remember, we have talked about in the drug in pregnancy and lactation, and the milk plasma ratio and the lipophilicity of the drug molecule that's going to affect beside the molecular weight. If it is greater than 700 Dalton, you see, then it cannot pass through these slits, and then active transport mechanism may be involved. So efflux transporters are there for drugs like levonclamide and digoxin, and if a drug is weak, basic drugs that accumulate more in the fetus, and therefore they are more teratogenic. So weak bases are much more teratogenic, and that should be usually avoided while going in pregnancy. But keep in mind, nowadays it is an era of evidence-based practice of medicine. So these could be one of the factors you see that's going to affect. But until and unless it is not evidence-based practice, evidence-based shown, you cannot go ahead, however, to use their drugs in pregnancy or lactation. And the passage of drug to testes, this is one aspect as well, because it's going to testes are special organ, you see, and the blood testes barrier is formed by a tight junction between the Sertoli cells, and lipophilic drugs can pass very easy by diffusion, and the hydrophilic drugs need special transporter, and the efflux transporters, some are there, and certain indication drugs are easily effluxed out. So you should keep in mind this point as well. So far the fluid compartments are concerned, and we will go to the volume of distribution, but keep in mind, as we talked about early in the compartment model, so there is extracellular fluid, there may be the plasma, there may be the interstitial fluid, and the intracellular fluid, and then the trans fluid. And keep in mind the statistic, which is self-explanatory. Now, patterns of distribution. Once we are going to study, you may study simply the plasma plus interstitial fluid, and the interstitial fluid plus plasma, and intracellular, and above all, in trans cases, that you consider all these compartments. So let me go one by one. So what will be the pattern of drug distribution among water compartments in the body? So let we go ahead. For example, if we think about that plasma is a plasma compartment only. So remember that cannot pass through the blood capillaries. Drugs, for example, very large molecular weight, which are belong to plasma protein. So usually for drugs with having volume of distribution like 3 to 4 liter, so and it will give you 0.05 liter per kg the volume of distribution. How this is given? This is calculated at this rate. For example, we take this 4 liter and then divide by 70 kgs in average adult weight, so it will give you this volume of distribution. And then if I carry you, so the higher the molecular weight, like this strain heparin, you see it cannot cross, and it needs a facilitated diffusion. Whereas when the total extracellular fluid can in case, so when we take this is considered especially in case which can pass through the blood capillaries but cannot pass through the cell membranes. Remember, and in this particular case, we consider the plasma plus the interstitial fluid. It means the drugs reach the from the blood. This is the blood, you see, and it reached the interstitial fluid, but cannot enter the nearby cells. These are nearby cells. This is if blood and drug is here, so it goes to the interstitial fluid, but cannot go to the cells. Keep in mind. So this is why this concept is considered here. So we will take the plasma volume because it is soluble in plasma, and then we think that it goes to the interstitial fluid. You see, so we will take the 3 liter usually on average plus 12 liter for the interstitial fluid. It will give you a total volume like this, and this total volume is then divided by 70 kg. You see, for respective volume of distribution for this one, and respective volume of distribution for this one, that will give you 0.2 liter per kg, the volume of distribution. Thus drug like mannitol, neostigmine, and streptomycin, which for low molecular weight and hydrophilic drugs, this requires much more volume of distribution as compared to other drugs. Now, pattern for distribution of drugs. That's water compartment in the body, among the water compartment in the body. And let we think about this. The total body water mean that can pass through the blood capillaries and the cell membrane. Now the drug is going out from the blood. Drug is here, and it goes to the interstitial fluid, and then this is another. Then the cells are there, so it means it comes out, reaches the interstitial fluid, plasma, plus interstitial fluid, plus it can cross the cell membrane of the cell and the cellular fluid as well. So here we will consider the extracellular fluid, interstitial fluid, and extracellular, intracellular, interstitial fluid. You see, intracellular concentration. So this is total 27 plus 15 liter. It will give you 42 liter. And in this case, you see, for example, we will consider the drug with low molecular weight and lipophilic. Why lipophilic? Because they are going to cross the membrane of the cells, and membrane is by phospholipid layer. You see, in case of skin, and in case of cell, it is having a single layer of phospholipid layer. Thus, a lipophilic drug, in case of lipophilic drug, you see, it passing from the blood, reaching the interstitial fluid, then reaching the cells inside the cell, passing the cell membrane. Consequently, we will consider all the volumes that come across within the way. So, thus 0.2 to 0.2 liter per kg and 0.4 liter per kg. It will give you 0.6 liter per kg. Mean the total volume of distribution will be for these two compartments, especially interstitial fluid and extracellular fluid. You see, and then drugs like diazepam, phenytoin, and then that can physostigmine or the tertiary amines, they will have a large plasma volume of distribution. And if this value, the volume of distribution, this value is greater than, what you can say, it is greater than 0.6 liter per kg, then it means more volume of distribution is required, and more volume of distribution mean that it is the amount of volume of drugs which does not exist inside the human body but requires much more. It means it is the apparent volume. So drugs like digoxin and chloroquine, you see, or amiodarone, they have a high volume of distribution, more than 42 liter, and if it is more than 42 liter, which is around about approximate inside the human body, if it is more than that, it means now this will become apparent volume of distribution. And what it will does, it will require much more volume of the fluid to carry the drugs. So thus the volume of distribution is the volume of fluid required to contain the total amount of drug. For example, if we consider that drug as drug A in the body, the same concentration is measured in the plasma, which is expressed as C. So for a single compartment, mean it goes from the central compartment to the tissues. The formula will be that volume of distribution is calculated by this formula, that A divided by C, where A is the amount of drug and C is the plasma concentration. Thus, it is an apparent volume of distribution, not a real one. For example, in case of drugs which required much more plasma volume, more than 42 liter, which is that of the human total volume, more than that, then that is why we call it as apparent volume. So what is important? Important to understand this, that this volume of distribution assumes that the drugs is evenly distributed while the drugs bind to the cellular components, like lipid, proteins, nucleic acid, and for the even distribution, we think that an equilibrium is maintained, and the total body water, that is 0.6 liter per kg, while that of some drugs have a more volume of distribution uh, required than 60 liter per kg. So it assumes that no drug is lost in the metabolism or excretion. It means high volume of distribution of a drugs is referring to the apparent volume. It's not actual volume. So thus calculation of volume of distribution is very critical so far the pharmacokinetic of a drug is concerned. When a drug A is injected, it reaches the blood, and from the blood, by definition, you see the volume of distribution is equal to the amount of drug that is administered divided by the total amount of drug divided by the amount of drug concentration inside the inside the blood. So how you will calculate the plasma volume of distribution? You see, if you go with example, and going with example, so if a dose of 1000 milligram is administered with the plasma concentration is 5 milligram per ml, so putting the value in this formula, so it will give you a 200 liter, and a 200 liter per 70 kg body weight means that's 2.9 liter per kg is the volume of distribution for this particular drug A drug. So you will use this formula. So thus volume of distribution is very important for when we know it of a particular drug, then we can easily target the blood concentration of a drug, and which is directly related to the response of a drug. And if you remember in the beginning, we said that we can control the response of a drug with studying the pharmacokinetic and the drug distribution model. So what is important to understand that certain drugs like warfarin has 8 liter of volume of distribution, tifarin has 30 liter of volume of distribution, whereas chloroquine has 15,000 liter volume of distribution. It means it is very slowly distributed and eliminated from the body. So importance of volume of distribution, that is, although it is not real, it gives you an indication and it tells you about the pattern of distribution, and it estimates the extravascular uptake of the drugs and whether it is small or large, and then it will help you how to calculate the targeted concentration of a drug inside the body, and at the same time you can calculate the loading dose and the desired maintenance dose. Most importantly, this concept also helps in the dialysis, especially if there is toxicological sign and symptoms of the aspirin is there, or any other drug like methadone. Certain diseases condition may alter the volume of distribution or increase it. Wow, because like if you consider that like liver cirrhosis or congestive heart failure, chronic renal failure, and it relates to the generalized edema, and then it poses hindrance to the as a barrier from crossing one compartment like blood. From blood it is then distributed to the interstitial fluid and then to the intracellular fluid. So this thickness of the membrane is increased, and consequently it is going to affect the distribution of drugs and pharmacokinetics of drugs. So therefore large volume of distribution increases the half-life of the drug, and that could be the reason that we consider this volume of distribution a very important parameter. Remember, it is related to the clearance of drugs, and clearance is the amount of plasma cleared per minute time, and this is how that volume of distribution is related to. So the higher the volume of distribution, the lesser will be the clearance, and vice versa. And in summary, distribution of drug and redistribution of drugs, like we talked about the phenytoin and the propofol, you see, and that can be very important, especially in the recovery phase when you use that phenytoin as drug of for the anesthetic purposes, for induction of anesthesia and maintenance of anesthesia. That is why propofol is nowadays used. So we discussed different factors. We discussed the plasma protein binding and it's going to affect how it's going to affect the pharmacological response of drugs, and then how the volume of distribution is calculated and how it is related to clearance and the targeted maintenance dose for the targeted pharmacological response. Thank you.